Urinary tract infections are classified by location. Lower urinary tract infections include bacterial cystitis, which is inflammation of the urinary bladder, bacterial prostatitis, inflammation of the prostate gland, and bacterial urethritis, inflammation of the urethra. These can be acute or chronic. Upper urinary tract infections are much less common and include acute or chronic pyelonephritis, which is the inflammation of the renal pelvis, interstitial nephritis, inflammation of the kidney, and renal abscesses. They can either be classified both upper and lower as uncomplicated or complicated. The bacteria that's most common cause of urinary tract infections is E. coli. That is the most common causative organism. The reason this happens could be from females is the wiping. They should be wiping front to back instead of back to front. It could also be an older adult that's wearing a TENS that the feces has mixed and gotten in that way with their urethra and moved up into the urinary system. It could also be urinary stasis. Urinary stasis has to do with risk factors for urinary tract infections. It could be the inability or failure to empty the bladder completely. It could be obstruction of urinary flow because of congenital abnormalities, strictures, tumors, stones, compression of the ureters. It could be also an instrumentation of the urinary tract, meaning someone got catheterized or had a cystoscopic procedure. It could be contributing factors, which are things like being female, having diabetes, being pregnant, having neurologic disorders, gout, and altered states caused by incomplete emptying of the bladder and having urinary stasis. Another cause of urinary tract infections is also decreased fluid intake. If there's not enough fluids to be flushing through the urinary system, it causes urinary stasis and an acidic environment for bacteria to grow. Another cause is reflux. That's the obstruction to free-flowing urine, and it's called a urethrovesical reflux. And this is a reflux that has a backward flow of urine from the urethra to the bladder. Also, with coughing, sneezing, or straining, the bladder pressure increases, which may force urine from the bladder into the urethra. Then when the pressure returns to normal, the urine flows back into the bladder, bringing into the bladder bacteria from the anterior portions of the urethra. Another type of reflux is the vesicocortical reflux, and that's the backward flow of urine from the bladder into one or both ureters. Clinical manifestations of urinary tract infection can be similar or vary dependent upon the age. In the adult, the signs and symptoms can vary. Half of the patients have no symptoms. Signs and symptoms of an uncomplicated lower urinary tract infection can include burning on urination, urinary frequency, which is voiding more than every 3 hours, urgency, meaning they have to go quickly, nocturia, which is awakening at night to urinate, incontinence, and suprapubic or pelvic pain. Now, blood in the urine, hematuria, and back pain may also be present. When we speak of the older adult, the gerontologic considerations, you need to think of what's happening in their lives. The UTI is the most common cause of acute bacterial sepsis in patients older than 65. In the older patient population, structural abnormalities secondary to decreased bladder tone and neurogenic bladder secondary to stroke or automatic neuropathy of diabetes may prevent complete emptying of the bladder and increase that risk of urinary tract infection. They also have indwelling catheters that can be used, and that dramatically increases that risk of urinary tract infections. Now, one of the Organisms responsible for urinary tract infections may differ from those found in patients just in the regular community. E. coli, once again, is the most common organism seen in older patients in the community or hospital. However, patients with indwelling catheters can be infected from organisms such as Proteus, Klebsiella, Pseudomonas, or Staphylococcus. The most common subjective presenting symptom of a urinary tract infection in an older adult is generalized fatigue. The most common objective finding is a change in cognitive functioning, especially in those with dementia, because these patients usually have even more profound cognitive changes with the onset of a urinary tract infection. In children, some of the clinical most common manifestations are fever, vomiting, dysuria, which is pain with urination, difficult urination, frequency, hesitancy, urgency, and the pain. In an infant, since they can't speak to you, you have to observe. So fevers, they can have vomiting, irritability, they can have failure to thrive because they're not eating. When infants don't feel well, they won't eat. And they can also have jaundice color. Nursing interventions utilized to help with urinary tract infections would be relieving pain, because pain that is associated with a UTI is very painful, but it can be quickly relieved once effective antimicrobial therapy is initiated. There are different types of antimicrobials or antibiotics or anti-infectives or bacteriocides that can be utilized. They can use things like macrodatin, Keflex, Cipro, Floxin, Levaquin. There's all types that can be utilized depending on the severity of that urinary tract infection. Also, what we want to do is have the patient drink liberal amounts of water, and to also avoid coffee, tea, citrus, spices, colas, and alcohol. Those are actually urinary tract irritants. We like our patient to frequently void, and that would be every 2 to 3 hours. We want them to maintain hygienic measures, which would include wiping for females front to back, and also no baths. We want them to have showers so that they're not sitting in water. We don't want any bubble baths. That wouldn't be helpful because that increases bacteria and the flow of that bacteria up into the urinary system. We also want to teach preventative measures, like I shared, no baths. We want them to void before and after sexual intercourse, having them normally void at least every 4 hours, and drinking liberal amounts of fluid, with once again avoiding that coffee, tea, citrus, spices, colas, and alcohol. Cellulitis pathophysiology is an acute streptococcal or staphylococcal infection of the skin and subcutaneous tissue. It is usually caused by Staphylococcus aureus. Now, cellulitis can occur at any age and can involve any skin area on the body. It can occur as an extension of a skin wound, as an ulcer, or from furnicles or carbuncles. Cellulitis can be associated with other diseases, including chronic venous insufficiency or stasis dermatitis. Clinical manifestations of cellulitis in a localized reaction will be erythema, pain, edema, and warmth at the site of the skin disruption. Treatment includes mild cases, usually with cephalexin or amoxicillin, clavulanic acid, and in more severe cases, and if it's periorbital or orbital cellulitis, it will require IV cephalosporins. Important factors of cellulitis are educating our parents and our patients if they're adults. We want to educate them in being clean, taking showers, drying appropriately, keeping fingernails short, especially in children, so that if they scratch, even if they scratch because of eczema, that it's not traumatizing the tissue and disrupting and giving a portal of entry for microorganisms. If the skin does disrupt, keeping that area very well cleaned, keeping it dry, and if there is a big skin disruption, that they need to go see a physician to see if they need to have antibiotics, whether it be topical or oral. With bacterial pneumonia, clinical manifestations are abrupt onset of fever, shaking or chills, a cough causing chest pain, purulent sputum, pleuritic type chest pain. When you do a physical assessment, you can hear consolidation of the lungs, and that is usually also manifested within a chest x-ray. Dullness to percussion over affected area with fremitus, because there's something solid so it sounds dull. Bronchophony, which is abnormal voice sounds heard over the lung with the voice too clear and high-pitched, indicating solidification. Egophony, which is increased resonance of voice sounds with a high-pitched bleeding quality heard especially over lung tissue compressed by pleural effusion. Bronchial breath sounds and crackles. Viral pneumonias are the most common causes of atypical pneumonia because of a viral infection. It has a gradual insidious onset. Patients can manifest with headaches, sore throats, muscle soreness, fatigue, dry cough, mucus sputum. They don't always have experiencing fever and chills. On physical assessment, you can hear scattered wheezes, crackles, and there may be little or no evidence of consolidation. In a chest x-ray, they may have minimal to substantial bilateral infiltrates. When we do labs, if we look at their white blood cells, they will be depressed slightly, less than 10,000. With pneumonia, we as nurses are going to utilize collaborative care. If it's a viral pneumonia, we do supportive care. We're going to give oxygen if needed, and if so, use a pulse oximetry to monitor. We're going to give hydration, PO, and IV. We're going to use aerosol therapy so that if the bronchioles need to be dilated, we can give medications. We can also use humidification with the oxygen if we need to. We can give antipyretics, antitussives, and antihistamines. We can also give nasal decongestants. Now, one thing that we need to be aware of is our geriatric patients. That supportive treatment also includes hydration, but we need to use with caution and with frequent assessment because they have a risk of fluid overload. In bacterial pneumonia, we're going to give oxygen once again if needed and monitor with pulse oximetry. But then we're also going to give antibiotics, and there's many different types of antibiotics that can be utilized. You have a chart actually in your digital textbook. We're going to give hydration therapy once again, aerosol therapy, and antipyretics. If needed, we can do chest physiotherapy and postural drainage to help facilitate the release and the expectorant of the mucus. Preventative measures is we're going to administer a pneumococcal vaccine and educate the patient to have a pneumococcal vaccine when initiated. Those who are at risk and need the pneumococcal vaccine are chronic illness patients, such as those who have heart and lung disease, those who have diabetes, those recovering from severe illness, 65 years of age or older, and those people who are in long-term care facilities. Hypothermia and frostbite is trauma from exposure to freezing temperatures and freezing of the intracellular fluid and fluids in the intracellular spaces. It results in cellular and vascular damage. It can result in venous stasis and thrombosis. Body parts most affected are the extremities, feet, hands, nose, and ears. The clinical manifestations will be that extremity may be hard, frozen, insensitive to touch, have a white color, or mottled blue-white color. Management for frostbite is to restore normal body temperature. Constrictive clothing and jewelry that could impair circulation are removed. Wet clothing is removed as rapidly as possible, and if lower extremities are involved, the patient should not be allowed to ambulate. Controlled rapid rewarming is instituted, so the frozen extremities are placed in a circulating bath that's from 37 degrees Celsius to 40 degrees Celsius for 30 to 40 minute spans. Pain medication is of the essence in patients. It is very painful once their body starts to be rewarmed. Do not massage body parts and do not handle affected body parts. This will cause further trauma and tissue damage. Once rewarmed, the part is protected from further injury and is elevated to control swelling. Sterile gauze or cotton is placed between affected fingers or toes to prevent maceration. A foot cradle may even be used to prevent contact with bedcloths if the feet are involved. After rewarming, hourly active motion of affected digits will be utilized. Discharge instructions for the patient will include avoiding tobacco, alcohol, and caffeine. Chronic obstructive pulmonary disease is a preventable and treatable slowly progressive respiratory disease of airflow obstruction involving the airways, pulmonary parenchyma, or both. COPD may include diseases that cause airflow obstruction, like emphysema and chronic bronchitis, or any combination of these disorders. Clinical manifestations are chronic cough, sputum production, dyspnea. Long-term clinical manifestations are a barrel chest and clubbing of the fingers. Interventions include teaching to breathing exercises, which is pursed lip breathing, diaphragmatic breathing, teaching to pace activities, teaching self-care activities, exercise, oxygen therapy, nutrition, and coping measures. Medications that are utilized for COPD are bronchodilators and corticosteroids. Bronchodilators receive bronchospasm by altering smooth muscle tone and reducing airway obstruction by allowing increased oxygen distribution throughout the lungs and improving alveolar ventilation. Asthma is a chronic inflammatory disease of the airways that causes airway hyperresponsiveness, mucosal edema, and mucus production. This inflammation ultimately leads to recurrent episodes of asthma symptoms, which include cough, chest tightness, wheezing, and dyspnea. The underlying pathology in asthma is reversible diffuse airway inflammation that leads to long-term airway narrowing. This narrowing, which is exacerbated by various changes in the airway, includes bronchoconstriction, airway edema, airway hyperresponsiveness, and airway remodeling. Now, there are age differences between the adult and the child. The children have narrow airways, which causes a greater increase in airway resistance, which is actually the effort or force needed to remove oxygen through the trachea to the lungs. Children's airways are smaller than adults, and they also have increased friction and resistance increase as air passes through the airway. Oxygen consumption in children is higher due to the metabolic rate being higher. And children also have fewer glycogen reserves, which means their muscles fatigue faster. There are triggers that elicit an asthma exacerbation. Things like smoke, dust mites, pet dander, cockroaches, indoor molds, pollen, and air pollution. To prevent infection in the hospital, we use isolation precautions. Isolation precautions are guidelines created to prevent transmission of microorganisms in the hospitals. There are two tiers of isolation precautions. The first tier is called standard precautions. It's designed for the care of all patients in the hospital and is the primary strategy for preventing healthcare infections. The premise of standard precautions is that all patients are colonized or infected with microorganisms, whether or not there are signs or symptoms, and that a uniform level of caution should be used in the care of all patients. The healthcare worker should use additional barriers in the form of personal protective equipment, including masks, eye protection, and cover gowns, depending on the expected degree of exposure to patient excretions or secretions. The elements of standard precautions include hand hygiene. Seeing Chart 71.1, you use alcohol-based if hands are not visibly soiled. You would hand wash with soap and water if hands are visibly soiled, if there is a C. difficile diagnosis, and healthcare workers that don't tolerate alcohol. We also have glove use. That is if you have any contact with any secretions or excretions. Another standard precaution is needle stick prevention. Do not recap needles. The fourth is avoid of splash or spray of body fluids. Using goggles and face mask and cover gowns help to avoid the splash or spray of body fluids. The second tier of isolation precautions is called transmission-based precautions. This includes droplet precautions, contact precautions, and airborne precautions. Droplet precautions are used with influenza and meningococcus. The transmission is limited to close contact. Healthcare providers should be wearing masks if within 3 to 6 feet of the patient. Since it is a close contact transmission, patient doors may be open. Contact precautions are for organisms that are spread by skin to skin, like C. difficile. Gown and gloves are required for contact precautions. Airborne precautions are for disease processes like tuberculosis and varicella. These patients must be placed in negative pressure rooms, meaning when the door opens, air goes in and not out of the room. The healthcare provider must wear an N95 respirator mask, and the patient's door must remain closed.
Within the concept of comfort is phantom limb pain. Phantom limb pain would occur because of an amputation. The major goals of a patient for the nurse is to relieve pain, wound healing, acceptance of altered body image, resolution of the grieving process, independence and self-care, restoration of physical mobility, and absence of complications. In relieving pain, the pain may be from incision or may be caused by inflammation, infection, or pressure on a bony prominence. The pain is described as if the amputated limb feels crushed, cramped, or twisted with an abnormal position. The pain sometimes is accompanied by numbness or tingling. The phantom pain occurs intermittently and unpredictably. Those episodes of pain may last for seconds or hours. Opioid analgesics may be effective in relieving this pain. Another intervention is to promote wound healing. The residual limb must be handled gently. Whenever the dressing is changed, aseptic technique is required to prevent wound infection and possible osteomyelitis. Enhancing body image is another intervention. The nurse encourages the patient to look at, feel, and care for the residual limb. It is important to identify the patient's strengths and resources to facilitate rehabilitation. The nurse helps the patient regain the previous level of independent living. In the concept of comfort, pre-procedure exemplar includes patient education and safety. One goal of preoperative nursing care is to educate the patient how to promote optimal lung expansion and resulting blood oxygenation after anesthesia. The patient assumes a sitting position to enhance lung expansion. Deep breathing, coughing, and incentive spirometry also help to promote lung expansion and blood oxygenation. A goal of promoting mobility postoperatively is to improve circulation. prevent venous stasis, and promote optimal respiratory function. The patient should be taught that early and frequent ambulation postoperatively, as tolerated, will help prevent complications. Pain management is an intervention that is essential. If there is no pain management, there won't be promoting wound healing. A pain assessment should include differentiation between acute and chronic pain. A pain intensity scale should be introduced and explained to the patient to promote more effective post-operative pain management. Explanation of the types of medications that could be offered for pain management are also included, to include the side effects. Safety is essential in pre-procedure. Some patients will receive a pre-anesthetic medication. If a pre-anesthetic medication is utilized, it is used with ambulatory or outpatient surgery minimally. If prescribed, it is usually administered in the preoperative holding area. If a pre-anesthetic medication is administered, the patient is kept in bed with the side rails up, because the medication can cause lightheadedness or drowsiness. We utilize fall precautions, especially, once again, if a patient is on sedatives and a patient has to void, we would offer a bedpan or a urinal to ensure the safety because of the lightheadedness or drowsiness from the pre-anesthetic medication. Another intervention is cognitive coping strategies. This will relieve tension and decrease fear overcome from anxiety. Opportunities to do that would be use of imagery, distraction, optimistic self-recitation, and music. In the concept of comfort is sickle cell exemplar. Sickle cell has crises. There are precipitating factors that precipitate a crisis. Cold temperatures, dehydration, low oxygen, infection, and stress can cause a crisis. There are 3 different types of crises. The acute vaso-occlusive crisis, which is the entrapment of red blood cells and white blood cells in microcirculation. This will cause tissue hypoxia, inflammation, and necrosis. Another crisis is called aplastic crisis. This is the infection with human parvovirus. Hemoglobin falls rapidly and marrow cannot compensate. Also, absence of reticulocytes will happen because of this. The third is sequestrian crisis, where organs pool sickled cells. In children, the most common site is the spleen, and in adults, the most common site is the liver. Pain is a significant issue. The incidence of painful sickle cell crises can be variable, and many patients have pain on a daily basis. Adequate hydration is important during the painful sickling episode. Oral hydration is acceptable if they can maintain the adequate fluid intake, or IV hydration can be acceptable. The use of medication to relieve acute pain is important. Aspirin can be useful in diminishing mild to moderate pain, and it also diminishes inflammation and potential thrombosis. Non-steroidal anti-inflammatory drugs are useful for moderate pain or in combination with those opioid analgesics. Pain levels should always be monitored using a pain intensity scale such as 0 to 10, and notifying and recognizing the quality of pain, like sharp, dull, or burning, or the frequency, consistent versus intermittent. With the concept of fluid and electrolytes, hypernatremia is an exemplar. Hypernatremia can be caused by a gain of sodium in excess of water or by loss of water in excess of sodium. It can occur in patients with normal fluid volume or those with fluid volume deficit. With a water loss, the patient loses more water than sodium, and as a result, the serum sodium concentration increases, and the increased concentration pulls fluid out of the cell. The etiology of hypernatremia can be excess water loss, which can be from burns, third spacing, or emesis. Another etiology is excess sodium administration, diabetes insipidus, heat stroke, or hypertonic IV solutions. A fluid deprivation in unconscious patients who cannot perceive, respond to, or communicate their thirst is also part of the pathophysiology. Less common causes of hypernatremia are heat stroke and near drowning in seawater, or malfunction of hemodialysis or peritoneal dialysis systems. Clinical manifestations include thirst, elevated temperature, dry, swollen tongue, sticky mucosa. Neurologic symptoms include apprehension, restlessness, and weakness. Please note that thirst may be impaired in elderly or the ill. Medical management includes giving back hypertonic electrolyte solution, or D5W. It consists of the gradual lowering of the serum sodium level by the infusion of a hypotonic electrolyte solution, or an isotonic non-saline solution. Nursing management would include assessment and prevention of hypernatremia, assess for over-the-counter sources of sodium, offer and encourage fluids to meet patient needs, and provide sufficient water if there are tube feedings. With the concept of fluid and electrolyte, fluid volume deficit and hypovolemia is an exemplar. The definition is the loss of extracellular fluid exceeds the intake of fluid. Now, the body has homeostatic mechanisms. It's equipped with remarkable mechanisms to keep the composition and volume of body fluid within narrow limits normal. Organs involved include the kidneys, heart, lungs, pituitary gland, adrenal gland, and parathyroid glands. Other mechanisms is the renin-angiotensin-aldosterone system. Renin is an enzyme that converts angiotensinogen, a substance formed by the liver, into angiotensin. Renin is released by the juxtaglomerular cells of the kidneys in response to decreased renal perfusion. Angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. The angiotensin 2 has vasoconstrictor properties, and it increases arterial perfusion pressure and stimulates thirst. As the sympathetic nervous system is stimulated, aldosterone is released in response to an increased release of renin, which will decrease urine production. Based on nursing assessment and mechanisms of injury, a likely cause of lower urine output would be the sympathetic nervous system being stimulated and aldosterone being released in response to the increased release of renin. As the sympathetic nervous system is stimulated, aldosterone is released in response to that increased release of renin, which decreases urine production. Management would include giving isotonic solutions. We would monitor INO, which is intake and output, the patient's weight, vital signs, level of consciousness, breath sounds, skin color, and skin turgor. We could give a fluid challenge if they're not excreting enough urine. The concept of elimination includes benign prostatic hyperplasia, or BPH, as an exemplar. The cause of BPH is not well understood, but testicular androgens have been implicated. It is a non-cancerous enlargement or hypertrophy of the prostate, and it is one of the most common diseases in aging men. Diagnostic findings can include obstructive and irritative symptoms during urinary frequency. They can have urgency, nocturia, hesitancy in starting urination, decrease in intermittent force of stream, and the sensation of incomplete bladder emptying. They can also have abdominal straining with urination, a decrease in the volume and force of the urinary stream. They can have dribbling, and complications of acute urinary retention and recurrent urinary tract infections. That can include azotemia, which it increases in nitrogenous waste products, which is the bun in your lab, and complications of urinary retention also include kidney failure. In the concept of elimination, diverticulitis is an exemplar. Diverticulitis results when food and bacteria retained in the diverticulum produce infection and inflammation that can impede drainage and lead to perforation or abscess formation. Signs and symptoms of diverticulosis are diarrhea, nausea, and anorexia. They can also have bloating or abdominal distension. Weakness, fatigue, and anorexia are common. With diverticulitis, the patient reports an acute onset of mild to severe pain in the left lower quadrant, accompanied by nausea, vomiting, fever, chills, and leukocytosis. This condition, if left untreated, can lead to peritonitis and septicemia. Complications of diverticulitis include peritonitis, abscess formation, fistulas, and bleeding. If you have complications, you must notify your physician immediately. If there's perforation, clinical manifestations would be abdominal pain, tenderness, abdominal rigidity, increased white blood cell, increased erythrosedimentation rate, increased temperature, tachycardia, and hypotension. If there's abdominal pain and rigid board-like abdomen, loss of bowel sounds, These signs and symptoms of shock occur with peritonitis. That would also include clinical manifestations of pain, tender and distended abdomen, which is also rigid, tachycardia, and hypotensive. Another complication is hemorrhage, and the last complication would be obstruction. In the concept of elimination, the exemplar diarrhea, which also encompasses Clostridium difficile. Infectious diarrhea results from infectious agents invading the intestinal mucosa. C. difficile is the most commonly identified agent in antibiotic-associated diarrhea in the hospital. Complications of diarrhea include the potential for cardiac dysrhythmias because of significant fluid and electrolyte loss, especially loss of potassium. Loss of bicarbonate with diarrhea can also lead to metabolic acidosis. Complications also can be muscle weakness, paresthesia, hypotension, anorexia, and drowsiness with, once again, those low potassium levels less than 3.5. Assessment and diagnostics findings would include checking for your complete blood count, serum chemistries, urinalysis, and stool examination for infections, parasites, bacterial toxins, blood, fat, and electrolytes.
And SaO2 tells you the oxygenation in pulse ox, by pulse ox. Okay, so I'm not going to review this again, but the steps for blood gas interpretation, first you need to identify if it's acidotic or alkalotic. So anything below 7.35 is acidosis, and anything greater than 7.45 is alkalosis. So big thing with this is that when we look and we identify if it's acidosis or alkalosis, then we need to look at our PaCO2 and then our bicarb. And whichever one is altered, we'll look at it, and we have to look at the direction that each component is going. So for example, if I have a low pH and a low bicarb, then I know that it's a metabolic issue because it's going in the same direction. If I had a low pH and a high CO2, then I know that it's a respiratory component. Okay, so we need to look and make sure first at each piece and identify acidosis or alkalosis, and then look at the bicarb and the PCO2 and see which one is affected and what direction it's going. And so a good acronym that you can use is ROME. Respiratory moves in opposite direction of pH. Okay? So just think of that, and then you'll always remember. Respiratory alkalosis is when the pH is high and the PaCO2 is low. So when the PaCO2 is low, that means that there's not enough CO2 in the blood. So when we think of patients that are anxious, they're hyperventilating, okay? So a lot of times they're breathing so fast that they're getting rid of all the CO2. So when that happens, usually we'll see it with patients that are anxious, they're hypoxemia, they've had like a salicylate intoxication, they may be pregnant. A big thing with this respiratory alkalosis we can see with pregnancy, because what happens is the uterus pushes up to the diaphragm, and it compresses up to the chest, and it kind of makes it harder for the lungs to expand. So the women that are pregnant, they breathe faster because that's their way of compensating for the anatomical changes that are occurring. Another thing we can also see with respiratory alkalosis if our ventilatory settings aren't changed. So this is why we do ABGs routinely, is because a lot of times if the rates are off and the gases aren't in sync with the vent settings, we may need to change them. Okay, so what do we see with some indications of respiratory alkalosis? You'll see numbness and tingling, inability to concentrate. You'll see loss of consciousness. You'll see tachycardia and ventricle and atrial dysrhythmia. Okay, so there's a lack of CO2, so you're going to have an alteration, and see here that a lot of times if you see that you're losing CO2, you're going to see that you're going to lose, you're going to have a deficit in your potassium. Okay, so that's important. So when you're looking at, in terms of respiratory alkalosis, you're going to see an anxious patient. So what are you going to do? You're going to have them stop and breathe through a paper bag because you want them to rebreathe that CO2, right? You're going to have them calm down. You'll give them anti-anxiety medications. You'll give them Xanax to calm them down. If it's a patient on a ventilator, you'll slow down the rate on the ventilator. Respiratory acidosis is when there's an inadequate excretion of CO2. So there's too much CO2 and there's a low pH. And so what happens, usually we'll see patients with pulmonary edema, aspiration, atelectasis, like if they're in respiratory distress, you'll see that. Sleep apnea, a pneumothorax, anything altering the pulmonary system, you're going to see respiratory acidosis. So typically when we have too much CO2 in our blood, if that happens, it's a vasoconstrictor. So what happens is we're going to have increased pulse, respirations, blood pressure, altered confusion, fullness of the head, and altered level of consciousness. So this just kind of tells you where what respiratory acidosis is, okay? And so in turn, you're going to see hyperkalemia, okay? So you'll see decreased blood pressure with vasodilation, rapid shallow respiration, headache, dysrhythmias due to potassium. So all these different alterations and changes. So what do we do for this? Well, we don't want to add more pressure to the heart because the pressure already is there because the fluid's not making its way in and out of the body. So what do? We try to maintain the blood pressure and help relax those vessels to make it easier for the heart to work. Okay? So we do this by doing the ACE inhibitors because we want to stop the angiotensin conversion enzyme, which is reabsorbing the sodium in the water. We can also use angiotensin receptor blockers, which are the same. They do the same effect. This is the Diovan would be an example. You can use beta blockers or hydralazine, and it's pretty much just to ease the workload of the heart. But the biggest thing with congestive heart failure, if you think about it, if a patient's heart is in right-sided failure, do we want to allow them to consume 3 liters of water? No, we don't. Because it's already backing up into the other side and creating systemic issues. So why would we encourage fluids? So a big thing with congestive heart failure is we want to limit the amount of fluids and make sure they're getting rid of any excessive fluids. So a lot of times these patients are on loop diuretics, the Lasix, and pretty much that kind of stops the sodium and the chloride to being absorbed. With diuretics, you want to make sure you're paying close attention to lab values because you can see alterations in your potassium levels. You also want to make sure anytime you're administering loop diuretics, you assess their blood pressure because the blood pressure, a lot of times they'll have hypotension. So we don't want to give them Lasix when they're already low on their blood pressure because that's going to wipe them and bring them completely down. Okay? So we don't want to do that. And we also want to make sure that they're urinating as much as what we want. If we're giving them a diuretic, we by right need to see output coming off. If there's no output coming off, then we have a problem. So we need to look at that in terms of making sure whatever they're taking in, they're letting off. And that the Lasix is effective because there is a lot of times we have to change our dosages of Lasix to meet the needs of the patient. What we usually see with the mitral valve prolapse is that what happens is that valve is not functioning correctly, and so it promotes promotes blood to go from the left ventricle back up in the left atrium. Okay, and so it kind of makes it more difficult. It doesn't keep it enclosed, if that makes sense. So typically what we see are some of the signs and symptoms are fatigue, shortness of breath, lightheadedness, dizziness, syncope, palpitations, chest pain, and anxiety. The important thing what you want to know is that somebody that has a mitral valve insufficiency, you won't see these symptoms all the time. So that's important that's an important instruction for you to include with your patient. because a lot of times if there's an indication that their mitral valve has, if there's a compromise at all in the patient, then you'll see these changes. If it's exacerbated.
The concept perfusion includes coronary artery disease, which we'll be discussing in myocardial infarction. The inflammatory process involved in the development of atherosclerosis begins with injury to the vascular endothelium and progresses over many years. A thrombus can form, which then will obstruct blood flow, leading to acute coronary syndrome, which may result in acute myocardial infarction. When a myocardial infarction occurs, a portion of the heart muscle no longer receives blood flow and becomes necrotic. Coronary artery disease produces symptoms and complications according to the location and degree of the narrowing of the arterial lumen, thrombus formation, and obstruction of blood flow to the myocardium. This impediment to blood flow is usually progressive, causing an inadequate blood supply that deprives the cardiac muscle cells of oxygen needed for their survival. This condition is known as ischemia. Angina pectoris refers to chest pain. Clinical manifestations would include that all ages and genders would have ischemia, angina pectoris or chest pain, epigastric distress, pain that radiates to the jaw or left arm, and shortness of breath. What are atypical symptoms, and mostly for women, is indigestion, nausea, palpitations, and numbness.
So great. Okay. Venous thrombosis, we see this a lot at warm springs, post-surgery, impaired mobility, any kind of patient where they're not moving around, or there's a possibility there's post-surgery because there's a lot of blood loss or alterations in if they have issues with their bleeding, or if they're on aspirin. No, not aspirin, sorry. If they're on Lovenox helps it, I'm sorry. But if there's an issue where they're immobile, or if they've post-surgery, they're at high risk of developing a clot in their leg. And so a lot of times what happens... Okay, so hemophilia is, it's a factor VIII deficiency. It's an X-linked recessive disorder. And what happens is that a lot of times with this we have to do a lot of patient teaching, because it is something that we have to administer at home, factor VIII. And so a big thing what we want to do is educate the families on injury prevention, because what happens is it makes them more susceptible to bleeding. Okay, so anytime they're around, a lot of times with kids, we'll tell them to put helmets on, we'll tell them to put knee pads on to protect them from injury. For adults, we'll just educate them and tell them, like we won't be able to tell them not to be doing contact sports, because that'll increase their likelihood of them getting injured. So we don't want that to happen. So we have to keep them very informed and aware that injury is something we don't want, because what happens is it can bleed in between the joints and can cause a lot of pain. Okay, we want to tell them to avoid NSAIDs like aspirin, because that increases their bleeding. Dental hygiene is important because of their risk for bleeding. We don't want to have to use any kind of implants or anything like that, because it'll increase their susceptibility of bleeding. First aid, we want anytime any kind of small cut or opening, we're going to apply pressure for at least a minute to make sure that the patient stops bleeding. Okay, because the likelihood of them bleeding is great. Okay, so the treatment of choice is the recombinant factor VIII administration. We use this more than the fresh frozen plasma. So we'll do the recombinant factor first, factor VIII. Okay.
For type 1 diabetes, the meal plan must consider the patient's food preferences, lifestyle, usual eating times, ethnic and cultural backgrounds. Patients who require insulin to help control blood glucose levels, maintaining as much consistency as possible in the amount of calories and carbohydrates ingested at each meal is essential. In addition, consistency in the amount time intervals between meals, with the addition of snacks if necessary, helps prevent hypoglycemic reactions and maintain overall blood glucose control. Blood glucose monitoring is a cornerstone of diabetes management. and self-monitoring of blood glucose levels has dramatically altered diabetes care. For type 1 diabetes, exogenous insulin must be administered for life because the body loses the ability to produce insulin. Chart 51.9, Guidelines to Follow During Periods of Illness, Sick Day Rules, in Hinkle, page 1444, is wonderful to help a nurse educate patients. We educate the patient to take insulin or oral antidiabetic agents as usual. They need to test their blood glucose and urine ketones every 3 to 4 hours. They need to report elevated glucose levels as specified or ketones in the urine. If a patient takes insulin during periods of illness, they may need supplemental doses of regular insulin every 3 to 4 hours. If they vomit, have diarrhea, or fever, they need to have liquids. They need to have every half to 1 hour to prevent dehydration and to provide calories. They must report nausea, vomiting, and diarrhea because extreme fluid loss can be dangerous. And if they're unable to retain oral fluids, they might have to be hospitalized to avoid diabetic ketoacidosis and possibly a coma. They would never eliminate their insulin when they have nausea and vomiting. The concept of metabolism with the exemplar diabetes has long-term complications. There are macrovascular complications and microvascular complications. Diabetic macrovascular complications result from changes in the medium to large blood vessels. Blood vessel walls thicken, sclerose, and become occluded by plaque that adheres to the vessel walls. Eventually, blood flow is blocked. The macrovascular complications are coronary artery disease, which they can have a myocardial infarction, cerebrovascular diseases, where they can have transient ischemic attacks or strokes, and also peripheral vascular disease. Microvascular complications can be characterized by capillary basement membrane thickening. The basement membrane surrounds the endothelial cells of the capillary. These microvascular complications can be diabetic retinopathy. Diabetic retinopathy is the leading cause of blindness among people between 20 and 74 years of age in the United States, and it occurs in both type 1 and type 2 diabetes. Another microvascular complication is nephropathy. Nephropathy, or kidney disease, is secondary to diabetic microvascular changes in the kidney. It is a common complication of diabetes. In the concept of metabolism, there is an exemplar of Addison's disease. Within the Addison's disease, as disease progresses, Addisonian crisis develops. This condition is characterized by hypotension, cyanosis, fever, nausea, vomiting, and classic signs of shock. The patient may also have pallor, complain of headache, abdominal pain, and diarrhea. They may also show signs of confusion and restlessness. Even slight overexertion, exposure to cold, acute infection, or a decrease in salt intake may lead to circulatory collapse, shock, and death if untreated. The stress of surgery or dehydration resulting from preparation for diagnostic tests or surgery may precipitate an Addisonian or hypotensive crisis. The exemplar psoriasis is considered one of the most common chronic non-communicable skin diseases. It's characterized by the appearance of silvery plaques that most commonly appear on the skin over the elbows, knees, scalp, lower back, and buttocks. Although lesions may appear anywhere, including the oral cavity, eyes, including the lids, conjunctiva and corneas, and joints. Onset can occur at any age, with a medium onset at 28 years. It is more prevalent among women and Caucasians and among persons who are obese. It is thought that most patients with psoriasis have a genetic predisposition to develop the disease. Psoriasis has a tendency to improve and then recur periodically throughout life. The pathophysiology of psoriasis, the current evidence supports an autoimmune basis. Periods of emotional stress and anxiety aggravate the condition, and trauma, infections, and seasonal and hormonal changes may also serve as triggers. The clinical manifestations may range in severity from a cosmetic source of annoyance to a physically disabling and disfiguring disorder. The lesions appear as red raised patches of skin covered with silvery scales. The scaly patches are formed by the buildup of living and dead skin. If the scales are scraped away, the dark red base of the lesion is exposed, producing multiple bleeding points. The patches are not moist and may be pruritic. In many cases, the nails are also involved with pitting, discoloration, crumbling beneath the free edges, and separation of the nail plate. Now, medical management, the goal is to slow the rapid turnover of the epidermis to promote resolution of the psoriatic lesions and to control the natural cycles of the disease. There is no known cure. The therapeutic approach should be one that the patient understands because they will be the ones who are providing the interventions and care. It should be cosmetically acceptable and minimally disfiguring of a lifestyle. Treatment involves the commitment of time and effort by the patient and possibly family. Any precipitating or aggravating factors are addressed. An assessment made of the lifestyle because psoriasis is significantly affected by stress. Gentle removal of scales is an important principle of psoriasis treatment. This can be accomplished by taking baths with added oils. There can be pharmacological therapy. There can be topical, phototherapy, and systemic. The concept of tissue integrity with the exemplar psoriasis, educating patients about self-care, is promoting home and community-based care. Printed patient education materials should be provided to reinforce face-to-face discussions about treatment guidelines and other considerations. Patients using topical corticosteroid preparations repeatedly on the face and around the eyes should be aware that cataract development is possible. Strict guidelines for applying these medications should be emphasized because overuse can result in skin atrophy, striae, and medication resistance. PUVA, which is reserved for moderate to severe psoriasis, produces photosensitization. The skin must be protected with sunscreen and clothing. Wraparound sunglasses should be worn to protect the eyes during and after treatment. An ophthalmic examination should be performed on a regular basis. Contraceptives should be used by sexually active women of reproductive age because the teratogenic effects of PUVA has not been determined. The exemplar impetigo is a bacterial skin infection. Impetigo is a superficial infection of the skin caused by staphylococci, streptococci, or multiple bacteria. Bullous impetigo, a more deep-seated infection of the skin, is caused by Staphylococcus aureus. It's characterized by the formation of a bullae. The exposed areas of the body, face, hands, neck, and extremities are most frequently involved. Now, impetigo is contagious and may spread to other parts of the patient's skin or to other members of the family who touch the patient or use towels or combs that are soiled with the exudate of the lesions. Impetigo is seen in people of all races and ages. It is particularly common in children living in poor hygienic conditions. Now, chronic health problems, poor hygiene, and malnutrition may predispose an adult to impetigo. The clinical manifestations are lesions that are most commonly seen on the face or extremities. They begin as small red macules, which quickly become discrete, thin-walled vesicles that rupture and become covered with a loosely adherent honey yellow crust. Now, these crusts are easily removed to reveal smooth red moist surfaces on which new crusts soon develop. Now, with the medical management, topical antibiotic therapy is usually prescribed when the disease is limited to a small area. Lesions are first soaked or washed with soap solution to remove the central site of bacterial growth, giving the topical antibiotic an opportunity to reach the infected site. After the crusts are removed, the prescribed topical antibiotic cream is applied. Now, gloves should be worn when providing patient care. Systemic antibiotics can be prescribed to treat infections that are widespread or in cases where they are systemic manifestations and if a fever is present. The nursing management includes when the nurse educates the patient and family to bathe at least once daily with bactericidal soap. Cleanliness and good hygiene practices help to prevent the spread of the lesions from one skin area to another and from one person to another. Patients and family members must be educated to practice hand hygiene every time after a lesion is touched. Each person should have a separate towel and washcloth. Because impetigo is contagious, infected people should avoid contact with other people until the lesions heal. The exemplar joint replacement is under the category of the mobility concept. Patients with severe joint pain and disability may undergo joint replacement. Conditions contributing to joint degeneration include osteoarthritis, rheumatoid arthritis, trauma, and congenital deformity. Some fractures, like a fracture of the femoral neck fracture, may cause disruption of the blood supply and subsequent death of tissue due to insufficient blood supply, which is called avascular necrosis. It also has to do with management with joint replacement may be elected over an open reduction. Joints frequently replaced include the hip, knee, and finger joints. More complex joints like the shoulder, elbow, wrist, and ankle are replaced less frequently. Nursing interventions when there is a joint replacement has to do with assessment of the patient and preoperative management. Those are aimed at having the patient in optimal health at the time of surgery. Nursing interventions also include preventing deep vein thrombosis. Patients having orthopedic surgery are particularly at risk for deep vein thrombosis and pulmonary embolism. The use of medications that increase the risk of clotting, such as certain hormones and NSAID drugs, may be discontinued a week before surgery. Assessing the neurovascular status of the extremity undergoing the joint replacement is important because post-operative assessment data are compared with pre-operative assessment data to identify changes and any arterial impairment to the affected extremity. Another nursing intervention is preventing infection. Any infection presenting 2 to 4 weeks before planned surgery may result in postponement of a surgery. Preoperative skin preparation, such as showers with antiseptic soap, frequently begins 1 or 2 days before the surgery. Culturing of the joint during surgery may be important in identifying and treating subsequent infections. The other intervention is managing pain. Assessment of the patient's pain preoperatively and any cultural and value preference are important components related to the control of pain following joint surgery. Assessing the patient's level of understanding of surgery and explaining what to expect can improve outcomes. A patient receiving total hip arthroplasty or hip replacement has many nursing diagnoses and nursing interventions. There is Chart 41-8, Plan of Nursing Care, in your Hinkle ebook, page 1119. Our nursing interventions would include assessing the patient for pain, asking the patient to describe that discomfort, and using pain-modifying techniques, after which we evaluate and record the discomfort. Also, nursing interventions that are included are maintaining proper position of the hip joint, which would be abduction, neutral rotation with limited flexion. We want to keep pressure off the heel. We want to instruct and assist in position changes and transfers. We offer encouragement and support exercise regimen. Also included is monitoring vital signs and observing for shock. We want to prevent hemorrhage or be aware if it is starting to happen. We note character and amount of drainage, and we notify the surgeon if the patient develops shock or excessive bleeding, and we prepare to administer fluids or blood component therapy and medications. We also monitor the hemoglobin and hematocrit values. We assess our neurovascular. We assess the extremity for color and temp, cap refill, edema, swelling, elevate the lower extremity, assess for deep throbbing, assess for pain on passive flexion, assess for change in sensation and numbness, and assess ability to move the foot and toes, assessing pedal pulses on both feet, and notifying the surgeon if altered neurovascular status is noted. In the concept of mobility, the exemplar osteoporosis has risk factors. In figure 42.7 in your ebook of Hinkle, page 1142, is a great chart. Genetics cause risk factors like Caucasian or Asian, female, family history, and small frame. That predisposes these people to low bone mass. Age is also a risk factor. Postmenopause, advanced age, low testosterone in men, and decreased calcitonin. Those have to do with the hormones of estrogen, calcitonin, and testosterone that inhibit bone loss. Nutrition is also a risk factor, having low calcium intake, low vitamin D intake, high phosphate intake, and inadequate calories. This will reduce nutrients needed for bone remodeling. Physical exercise of being sedentary, lack of weight-bearing exercise, and low weight and body mass index, because bones need stress for bone maintenance. Lifestyle choices such as intake of caffeine, alcohol, smoking, and lack exposure to sunlight reduces the osteogenesis and bone remodeling. Medications such as corticosteroids, anti-seizure medications, heparin, thyroid hormone affect calcium absorption and metabolism. The medical management for osteoporosis includes a diet rich in calcium and vitamin D throughout life, with also an increased calcium intake during adolescence and the middle years, which would protect against skeletal demineralization. Rich in calcium and vitamin D is of the essence for nutrition. Weight-bearing with regular weight-bearing exercise promotes bone formation. Medications, which is the pharmacological therapy, we have first-line medications used to treat and prevent osteoporosis, including calcium and vitamin D supplements, and biophosphates for both genders. The biophosphates, like Fosamax and Boniva, increase bone mass. An anabolic agent, Forteo, stimulates bone matrix and facilitates calcium absorption. In the concept of sensory, the exemplar glaucoma has nursing management, which includes patient education. There is a chart on 63.6, Managing Glaucoma, in your Hinkle ebook, page 1857. Know your intraocular pressure measurement and the desired range. Be informed about the extent of your vision loss and optic nerve damage. Also educate the patient about the strict medication regimen. Their medications can have interactions with other medications, such as if they take Diamox, it has a diuretic effect. If they take miotics, it can alter their focus. Also, the disease has a familial tendency. What is prescribed and what is recommended is to have family members' eye examinations once every 2 years. The concept of sensory, cataracts is an exemplar. A cataract is a lens opacity or cloudiness. It affects nearly 24.4 million Americans who are 40 years or older. Cataract is a leading cause of blindness in the world. The medical management would include the risk reduction of cataract formation, having the patient with smoking cessation, weight reduction, blood sugar control for diabetic patients, and wearing of sunglasses. Surgical intervention is an option. A no non-surgical treatment, such as medication, eye drops, or eyeglasses, cures cataracts or prevents age-related cataracts. With the exemplar of cataracts, there is surgical management, and there's a teaching chart, 63.9, in your Hinkle ebook under Home Care Checklist, page 1861. It suggests for the patient to wear glasses or eye shields after surgery, avoid lying on the side of the affected eye, keeping activity light, avoiding pushing, lifting objects heavier than 15 pounds, and definitely knowing when to contact the ophthalmologist. They need to contact the ophthalmologist if they have any vision changes, continuous flashing lights, redness, pain, or swelling that increases in the affected eye drainage changes, eye that gets injured, and pain not relieved by acetaminophen. In Alzheimer's disease, nursing management plays an important role in the recognition of dementia, particularly in hospitalized older adults, by assessing for signs, repeating or asking the same thing over and over, or getting lost. During the nursing admission assessment, we assess for these symptoms. Nursing interventions are aimed at promoting patient function and independence for as long as possible. Other important goals include promoting the patient's physical safety, promoting independence and self-care activities, reducing anxiety and agitation, improving communication, providing for socialization and intimacy, providing adequate nutrition, and promoting activity balanced with rest. Supporting and educating family caregivers is also an important role that nurses play. These nursing interventions apply to all patients, regardless of the cause. With the concept of coping, peptic ulcer disease exemplar is an excavation, which is a hollowed-out area that forms a mucosal wall of the stomach or pylorus or duodenum or esophagus caused by erosion. This erosion may extend to the peritoneum. The pathophysiology of peptic ulcer disease is that of a bacteria called H. pylori. A risk factor is the use of NSAIDs such as ibuprofen and aspirin. There are predisposing factors such as familial tendency for peptic ulcer disease, and peptic ulcer disease with rare cases are patients with tumors. Peptic ulcers occur mainly in the gastroduodenal mucosa because this tissue cannot withstand the digestive action of gastric acid and pepsin. The erosion is caused by the increased concentration or activity of acid pepsin or by decreased resistance of the mucosa. A damaged mucosa cannot secrete enough mucus to act as a barrier against this activity of acid pepsin. In the coping concept, neonatal abstinence syndromes exemplar. Newborns of women who abuse tobacco, illicit substances, caffeine, and alcohol can exhibit withdrawal behavior. Drug dependency acquired in utero is manifested by a constellation of neurologic and physical behaviors and is known as the neonatal abstinence syndrome. Although often treated as a single entity, neonatal abstinence syndrome is not a single pathologic condition. Neonatal abstinence syndrome has both medical and developmental consequences for the newborn. In the neonatal abstinence syndrome, manifestations are noted in box 24.4 in your Ricky ebook, page 861. It's categorized under CNS dysfunction, metabolic, vasomotor, and respiratory disturbances, and gastrointestinal dysfunction. There is also a picture noted to show these clinical manifestations. You can read them and note that tremors, general seizures, shrill, high-pitched cry are noted under the central nervous system dysfunction. With the metabolic, vasomotor, respiratory, frequent yawning, mottling of skin, frequent sneezing, nasal flaring, and tachypnea are also part of the manifestations. And with gastrointestinal, poor feeding, frantic sucking, and loose watery stools are noted. Nursing management of neonatal abstinence syndrome has major goals which include providing comfort to the newborn by relieving symptoms, improving feeding and weight gain, preventing seizures, promoting mother-newborn interactions, and reducing the incidence of newborn mortality and abnormal development. Providing comfort includes decreasing stimuli, dimming lights, swaddling the newborn, gently rocking, putting the patient in a flexed position, letting the patient utilize a pacifier, always having a calm, gentle approach, and giving the patient rest periods, which we can also call cluster care, which is gathering all of your equipment and your interventions and doing them all at once and not going in and out of the room so the patient has time to rest. In meeting the nutritional needs, small, frequent feeds and positioning them upright is vital in meeting those nutritional needs. Assessing hydration, which includes assessing skin turgor and fontanelles. Preventing complications and promoting parent-newborn interaction is part of nursing management for neonatal abstinence syndrome. In the concept of functional ability, Parkinson's exemplar. Parkinson's disease is associated with decreased levels of dopamine resulting from degeneration of dopamine storage cells in the basal ganglia region of the brain. The loss of dopamine stores in this area of the brain results in more excitatory neurotransmitters than inhibitory neurotransmitters, leading to an imbalance that affects voluntary movement. Parkinson's disease has a gradual onset and symptoms progress slowly over a chronic, prolonged course. The cardinal signs are tremor, rigidity, bradykinesia, and postural instability. Other manifestations can include excessive sweating, paroxysmal flushing, orthostatic hypotension, gastric and urinary retention. Psychiatric symptoms are depression, anxiety, hallucination, dementia, and delirium. With the tremor, they are present at rest, but they increase tremors when walking, concentrating, or anxious. The rigidity is resistant to passive limb movement. Bradykinesia is the overall slowing of active movement, and postural instability is the forward flexion of the neck, hips, knees, and elbows. In the concept functional ability, multiple sclerosis is the exemplar. Multiple sclerosis is an immune-mediated, progressive, demyelinating disease of the central nervous system. Demyelination refers to the destruction of myelin, which is the fatty and protein material that surrounds certain nerve fibers in the brain and spinal cord. It results in impaired transmission of nerve impulses. Clinical manifestations include fatigue, so patients should avoid hot temperatures and rest in cool areas. Depression is one. Weakness. If they have weakness, they should frequently have short rest periods. Numbness is a clinical manifestation. Difficulty in coordination. They need gait training. Loss of balance. Spasticity. Utilizing baclofen and/or benzodiazepines can help with the spasticity. Also, muscle stretching can help. Patients can have pain, which they would utilize analgesics. And another clinical manifestation is visual disturbances. Nutrition is important to maintain health and to prevent disease and death. When illness or injury occurs, optimal nutrition is essential for healing and for resisting infection and other complications. Components of a nutritional assessment, there is a sequence of assessment parameters that may vary. However, evaluation of nutritional status includes these following methods: measurement of body mass index, or the BMI, waist circumference, biochemical assessment, clinical examination findings, and dietary data. The measurement of BMI and waist circumference is recommended to determine if a patient is obese. The BMI ratio based on base body weight and height. The obtained value is compared to the established standards. The BMI is highly correlated with body fat, although increased lean body mass or a large body frame can also increase the BMI. In nutrition, it's important to consider lifespan considerations. Adolescence is a time of critical growth and when lifelong eating habits are established. Nutritional assessment is particularly important during this time period. It is vital to assess for obesity in adolescents to prevent complications from obesity as they enter adulthood. Adolescent girls are at a particular nutritional risk because iron, folate, and calcium intakes are below recommended levels, and they are less physically active group compared to adolescent males. Adolescents with other nutritional disorders such as anorexia and bulimia have a better chance of recovery if these disorders are identified and treated in the adolescent years rather than the adulthood. Gastrostomy and enteral feedings are exemplar under nutrition. Gastrointestinal intubation is the insertion of a flexible tube into the stomach or beyond the pylorus into the duodenum or the jejunum. The tubes may be inserted through the mouth, the nose, or the abdominal wall. The tubes are obviously of various diameters and length depending on their intended use. The purpose of GI intubation may be performed in order to decompress the stomach and remove gas and fluid, lavage, which is flush with water or other fluids and remove ingested toxins or other harmful materials, diagnose GI disorders, administer tube feedings, fluids, and medications, compress a bleeding site, or aspirate GI contents for analysis. The different types of tubes depend on the diagnosis. Within these tubes, we do nursing management. We prepare the patient prior to the insertion to promote cooperation during the procedure. Once placed, we confirm placement. To ensure patient safety, it's essential to confirm the tube has been placed correctly. The tip of the tube may be in the esophagus, stomach, or small intestine. It may also inadvertently be inserted in the lungs, most commonly in the right main stem bronchus. Inappropriate placement may occur in patients with decreased level of consciousness, confused mental states, poor absent gag, or cough reflexes, or agitation during insertion. Also, what must be assessed is clearing tube obstruction. If it's difficult to instill withdrawal warm water into a clogged feeding tube, several declogging steps can be taken, including warm water penetration, milking the tube, infusing digestive enzymes, and employing mechanical declogging devices. When the tube is first noted to be clogged, a 30 to 60 ml syringe should be attached to the end of the tube and any contents aspirated and discarded. Then the syringe should be filled with warm water, attached to the tube again, and a back and forth motion initiated to help loosen the clog. Clearing tube obstructions is essential so that medications can be input or drainage can be expelled. Also, the nurse must provide oral and nasal hygiene. It is essential to have regular conscious oral and nasal hygiene because the tube causes discomfort and pressure and may be in place for an extended length of time. The nose is inspected daily for irritation and the tape is changed every 2 to 3 days. The nurse must also monitor and manage potential complications. Patients with these NG intubations are susceptible to a variety of problems, including fluid volume deficit, pulmonary complications, and tube-related irritations. These potential complications require careful ongoing assessment. Before inserting the tube, the nurse determines the length that will be needed to reach the stomach or the small intestine. A mark is made on the tube to indicate the desired length. This length is determined by measuring the distance from the tip of the nose to the earlobe and from the earlobe to the xiphoid process. During insertion, the patient usually sits upright with a towel or other protective barrier, like a bib-like fashion over the chest. The nostril may be swabbed or the oropharynx sprayed with an anesthetic agent to numb the nasal passage and suppress the gag reflex. With the concept of cognition, this is the delirium exemplar. Once delirium occurs, treatment of the underlying cause is most important. Therapeutic interventions vary depending on the cause. Delirium increases the risk of falls, therefore management of patient safety and behavioral problems is essential. Because medication interactions and toxicity are often implicated, non-essential medications should be discontinued. Nutritional fluid intake should be supervised and monitored. The environment should be quiet and calm. To increase function and comfort, the nurse provides familiar environmental cues and encourages family members or friends to touch and talk to the patient. Ongoing mental status assessments using prior mental cognitive status as a baseline are helpful in evaluating responses to treatment and upon admission to a hospital or extended care facility.